Okay, getting started here with Performance School, second one of the semester. So definitely excited to have Dr. Michael Gay from Athletic Training here at Penn State. Going to let him kind of introduce some of his work that he's done in the past. But just like we always do, want to just celebrate how cool a learning community is. It doesn't matter if it's in an organization, if it's in an institution, or in this case, an athletic department. So we want to continue to extend the invite to different people around Penn State. I'd like to welcome some new people that we've had for the first time here on University Park campus, but also we've extended the invite to some of the satellite campuses around Penn State and the Commonwealth. So anybody that's new here, I really appreciate you joining us. And just kind of a little bit of a logistics thing. We do this every other Wednesday at noon, and we have different people try to keep it within the Penn State community, but we have had some guests come in the past and talk just all things performance. Performance can be physical, mental, anything on the spectrum of just improving performance of athletes, of coaches, staff, or just us as people. We all got one mission, and that's to move Penn State forward and our athletes forward. So that's the biggest thing. I will say this is being recorded. I like to package this and put it on YouTube so we can disseminate it to people that maybe were unable to attend, or, for past or future reference. If anybody has something that pops up in one of these that you maybe don't want shared, please reach out to me and we cannot share that. We can just archive that and it won't be public. But we do like to just kind of keep everything professional so that we can move forward with sharing it and just building our knowledge base, because that's at the end of the day what we're trying to do. Snapshot of what we have throughout the rest of the semester here. We have people representation from strength and conditioning here on Penn State's campus. We have some former alumni that now operate a rehab and recovery business out of California that will be joining us. We have both Carl and Adriana from performance psychology that will be with us. We do have a guest from the United States Olympic Committee that works in coaching education that'll come in April. And then we have some Nicole DeFerrari from the Counseling and Psychology Department. She will join us. And our last one of the semester, we're fortunate to have Mitch Gerber from Go Penn State Sports, and he's going to lead a conversation about all things in his area. So without further ado, I will pass this over to Mike. You should have full control, brother, and we're ready to go, man.
You're muted, Mike.
Rookie, right? It's only been, what, a year now? Come on, Gay, get it together. All right, so everybody, you guys can see this presentation all right? I want to apologize ahead of time because we're going to get into the weeds a little bit, and you'll have to forgive me. But concussion is a topic that's been pretty hot for a while before this whole COVID thing rolled into town. Concussion was pretty widely talked about. It's been a raging topic for the past probably about 2 decades. And there's been some really key findings of late that we'll get into. But what I'm going to talk more about today are the problems or the presentation of concussion, how it's currently presented in our area in terms of athletic training, physical therapy, and then what brain science tells us about traumatic brain injury and sport-related concussion and the physiology that underlines what you see at a clinical level. All right, so we'll talk a little bit about incidence, definition of mild traumatic brain injury, the mechanisms and the physiology of injury. We'll last take a look at neuroimaging and then some treatment approaches for traumatic brain injury. And again, we're just really gonna glaze over the top of a lot of these areas. There's a lot to get into. And so I just want to sort of give you an idea of the flavor for what we do as a lab. Dr. Slobanoff, I can't go any further without acknowledging you and your importance here in developing my mindset for concussion and my understanding of the neurophysiological underpinnings of concussion and traumatic brain injury. So I just want to thank Dr. Slobanoff for his lifetime of work with us at Penn State. But so here's your obligatory incident slide, right? We all know that concussions happen. They happen with a great amount of frequency. Roughly 1 in 5 of all concussions are related to sports. So that's our area. That's where we need to step in and sort of manage these athletes as they come into our athletic training rooms, and we manage them on the field. And then also in the short-term and long-term care of those athletes. There's been a recent focus on concussion over the past decade that's really focused on state law. Initially, you have some state legislation that took place in the early 2000s at the turn of the decade with Max's law in the state of Oregon, and then the Zach-Lestat law in the state of Washington, somewhere around the 2008, 2009 area. And so then there was a series of legislative movements that really progressed concussion and how we're treating with concussion. You can see some of these landmark areas in 2010, 2012. 2010 was the first time the NCAA mandated concussion management plans. So it's really not that long ago. And then in 2012, formation of the Big Ten Ivy League consortium, it's research collaboration. And then you have a series of lawsuits and class actions that sort of drove care up until 2014 when they launched the large care consortium, which was established. Then you can see lawsuit after lawsuit has sort of shaped how we manage and deal with concussion over the years. A lot of work and a lot of litigation, a lot of legal action has really sort of resulted in the last decade of how clinicians are to manage concussion. So one of the classic definitions of concussion has to do with where the concussion and sports group that meets on a quadrennial basis, meaning every 4 years since the year 2000, a group of selected individuals and scientists get together and form and inform us how we're going to treat concussion for the next 4 years. So the good news is that hasn't changed much. The bad news is that hasn't changed much. So in 2000, we sort of started off by saying that concussion is a brain injury that's defined as a complex pathophysiological process affecting the brain, and it's induced by biomechanical forces. They can be forces to the body or forces to the head. The problem in some of the definitions and how clinics are presented with this is they're reflected as a functional disturbance of the brain rather than a structural injury. And this is a key component that I think we're spending too much time focusing on the wrong area, or an incomplete time focusing on incomplete data. So we're looking at functional disturbances rather than structural injuries. And the problem with that is that we've reduced concussion down to a series of functional aspects, meaning we can measure a symptom and then say once that symptom is no longer there, then we're calling that healing, right? We're going to call that healing in the functional domain. The problem is we also have sort of the elephant in the room of all kinds of a litany of long-term consequences. And this research is growing and growing and growing. There's behavioral issues, anxiety, depression, mood disorders, post-traumatic stress, substance use disorder. There's physical problems with headache, chronic fatigue, physical disturbance in the body. And then there's these underlying physiological processes like tauopathies, various tauopathies that are unleashed in the brain, that we have a definite cause in trauma that's leading to the hyperactivity of these tauopathies. So you need to really think of concussion in terms of two houses, both structure and function. Both of those are together. They're not independent of one another. And when function goes away, we still have structural problems. And I can demonstrate that quickly throughout this lecture. So what are some of the mechanisms that cause damage to the brain? There are compressive forces, tensile forces, rotational forces. The brain is made mostly of water, or there's a high concentration of water, so it's resistant to compressive forces, but it's very, very weak in terms of tensile or shear resilience properties. So when these pathophysiological changes are made, they result in ultrastructural changes to the white matter in the brain, which are the axons or tracts in the brain. There's also a disruption of cellular membranes, both within the cell itself, the soma, as well as some of the organelles that are altered inside of those cells, which lead to ultimately to metabolic alteration. There's vascular problems, and there's issues with mitochondrial function in the brain. I told you we're going to get into the weeds here, so just bear with me. I thought I got rid of these. That's Bush League right there. All these little animations. I thought I got rid of those. My fault. So in the acute damage phase to the neural tissue, there's a primary damage that happens as a result of those shear forces that actually can cause direct damage to the cell itself. They're responsible for focal lesions. They're responsible for vascular compromise in the area in terms of microbleeds or perivascular deposition of iron. And then they are also responsible for the initial beginning of various downstream tauopathies and other really damaging byproducts. The secondary sequelae, or the subacute stage, the brain is often left with ischemic areas or areas in the brain where are hyperperfused, meaning they don't get adequate amounts of blood supply to sustain metabolic activities. There is a shift in metabolic substrate that's used in the brain. So the brain starts using different forms of energy availability, and that's not necessarily a bad thing. It can actually be neuroprotective in some ways. But for our purposes, it shifts how the brain starts utilizing energy. And then thirdly, there's a neuroinflammatory response, and we'll talk a little bit about that too. So first off, the circulatory changes, there's vasoconstriction of the local areas of damage, which leads to an alteration of sort of that oxygen or carbohydrate or carbon dioxide concentrations, which can be damaging and alter the cerebrovascular reactivity of that area in the brain. All that means is that when you've damaged an area, now you've changed how blood can enter that area and then also assist in the healing process. And a lot of studies on people with chronic post-concussion syndrome, we see altered areas of perfusion all around the brain. And so treatment for that person would include the restoration of the hypoperfused areas. In terms of the metabolic changes that happen, they're primarily linked to mitochondrial dysfunction in the brain. The neurotransmitters that are released as a result of damage, glutamate in particular, potassium into the extracellular space, lead to a damaging effect of the soma and the axon. They also cause problems with the cell walls and increase your ATP demand for that cell to then heal itself or return itself back to homeostasis. The cell is always trying to get back to a state of normalization, and it has to do that under conditions where it needs more energy. And then lastly, you talked about a shift in substrate utilization. There's a shift in the use of lactate and pyruvate as energy sources in the brain for ATP production. So it changes to more of an anabolic mode of energy production. And it's not readily accepting glucose as it would normally in normal function. So there's a decreased glucose use in the cell, and there's various underlying mechanisms that cause that shift and cause that change. That's an entirely different presentation. So again, a lot of these things that we're talking about are that I'm just brushing on are expanded greatly in the research. As far as the last part there's a neuroinflammatory response, your creation of reactive oxygen species that are a result of lysing of cell walls and disruption of membranes. And then what you get is a macroglial or activated microglial response in the brain, which is the inflammatory response So those cells come in, clean up the debris, and then begin releasing growth factors and cytokines that promote regeneration and growth, right? And some of those cytokines are like TNF alpha, brain-derived neurotropic growth factors, neurotroponin 3 and 4 are common ones. And those are all cytokines that are released in the brain afterwards as a result of trauma that help the brain heal. In terms of chronic functional disruption, so there's two separate processes that can happen. One is a gray matter response that's largely focused to the cell or the body of neurons. The neurons in the cells themselves have the organelles or have the ability to heal a little bit quicker than the axonal part of the neuron. And healing can be demonstrated in the literature, and imaging, it can be less than 30 days. For white matter responses, that healing time can take months, years longer. We've seen plenty of studies with diffuse tensor imaging that have demonstrated decrements in function lasting greater than a year. We've done a variety of that research. We've demonstrated issues at both the acute, subacute stage, as well as the chronic or long-term stages. So again, these healing processes that happen in the axon of the neuron can take much, much longer. And then also you see the tau protein activation as a result of traumatic brain injury. So tau is not a bad protein, all right? It gets a rap because it's being talked about a lot in terms of its hyper production. Tau proteins are actually needed in the brain to stabilize axons and stabilize the scaffolding that goes into the axon. So tau proteins themselves are not the problem. What is the problem is the hyperphosphorylation of the tau proteins and the deposit of those proteins at intervals around the brain that can lead to chronic long-term dysfunction and ultimately behavioral changes and some of the tauopathies that we talk about, like CTE, Alzheimer's, those types of things. So how do we currently assess? So given this large body of data and this huge amount of information about the physiological processes that underlie brain trauma, how do we currently assess these pathophysiological processes? Well, we don't. What do? We do neuropsychological testing, which is a functional test. We do balance testing, which is functional. Cranial nerve assessment, we ask them how they're feeling. We look at eye movement. We look at reflexive testing. We look at movement screens. All of these measures are wonderful clinical measures, and they've been validated in the research to capture people with problems. But they're clinical methods, and they're limited at best. And I need that point to sink in. The best we can do right now in clinical measure is incomplete evaluation of brain trauma. That's at our best. We do not readily use physiological data points in order to inform our healing process. So again, at best, we are limited. So what are some of these potential physiological biomarkers, right? We hear a little bit about blood biomarkers. You look at neuroimaging techniques, which will give you a hint as to neurophysiological function. You can look at EEG data, which gives us an idea of the upper layers of electrical output for the brain. And then there's some other alternatives like functional FNIRS, which is a near-red infrared spectroscopy, which is sort of like imaging, but it uses a different, it uses light as a source for identifying areas that are have concentrations in blood flow. So those areas are outlined or evaluated using infrared technology. So what are the things that were some of the more important biomarkers that are in the literature are, you have these NFTs, tau, you've got glial fibrillary acid protein, GFAP, and then SP100, which is becoming a little bit more robust now in the research. So we're looking at axonal damage. One of the primary biomarkers we look at is neurofilaments. It's an intermediate filament found in axons and nerve cells. It serves as a component of that cytoskeleton for the scaffolding. Evidence of the presence of this in blood is indicative of damage to the axons. You have a level of this found in the blood or C-spine fluid post-trauma that is indicative of axonal damage. In addition, you see the release of tau proteins, which are released in terms of stabilizing axons as well. They're a scaffolding protein, and they're used to help reinforce axonal scaffolding. And the evidence of this that's chronic in the brain is seen for in terms of hyperphosphorylation is Alzheimer's, dementia, and other CTEs. But again, what we're learning more about the hyperphosphorylation of tau proteins is not only that they're present, but where they're present. So are these proteins accumulating in the extracellular space, or are they accumulating around the axon? Or are they accumulating around the terminal end branches? Are they accumulating around an area of function? So you can have tau protein deposition in the brain and have and clinically present neurotypical, meaning you don't have maybe you don't have behavioral issues, maybe you don't suffer from mental illness, maybe you don't have chronic fatigue and other issues, because your tau deposition is location specific. So just to add another little flavor or layer to it, the presence of tau itself is not the issue, it's location specific that causes the problem. In terms of glial damage, and glial cells are other cells that are located surrounding the neurons. You have GFAP, which is a glial fibrillary acid protein. It's involved in the astrocyte cytoskeleton. And then SB100 is also a structural component. It's used in the functional extension of neurites. It helps regulate calcium intake and outtake of the cell, and it's used for acute stage TBI biomarker. And some research is actually starting to use biomarkers to help inform some of their imaging in the acute stage or subacute stage. So one of the issues you see with using biomarkers is a chart like this. This is from a study by Neuroscience in 2016, and it shows you roughly the milieu or mix of some of the biomarkers levels that happen after TBI in the hours and days following injury. So again, you can sort of see how these markers rise and fall over time, and then it gives you an idea that the complexity with which it would take to use these biomarkers. Now, one thing of note here is that neurofibular, the NF biomarker, has a tendency to stay elevated post-trauma. So that, in conjunction with the SB100 biomarker is often reduced back to near normal levels. So what we're starting to see is the potential for SB100 to help inform our use of that biomarker along with others. So it actually, a very recent study out of France is using blood biomarkers and then also some other biomarkers, SB100 marker to help inform their imaging decision-making strategies. So you can see here the decision tree they use in order to decide whether they're going to image somebody and look for microbleeds or other sort of macro level tissue damage. This is a good step. I'd love to see us do some serial biomarker testing over time. And in fact, in some of the studies that we did with Penn State football, we've done that. And so we're looking and continuing to look for useful ways we can incorporate physiology back into the clinical underpinnings of how we evaluate and treat athletes and people with they're recovering from sport-related concussion. By the way, I'm going to not breathe very much during this presentation because I'm trying to plow through it. So if somebody wants to jump in or chime in or raise a hand, please feel free to do so. I love to talk things out as well. So if y'all want to just wait till the end, that's fine too. Maybe I should have said that when we got started, but sorry about that. So let's now shift from blood biomarkers or something that we can get in cerebrospinal fluid to neuroimaging techniques. And there's conventional MRI and CT scans, which are typically negative and oftentimes never prescribed, at least in the acute or subacute stage. Functional imaging, advanced imaging, is something that has a huge value in terms of delineating and giving us additional physiological input into the complex milieu of the brain metabolic activity post-concussion. So we use a lot of different techniques to measure brain physiology and the underpinnings of injury with these techniques. And we have these advanced imaging techniques here on campus. Some of the scans that we like to run, this again, the DTI is an evaluation of the functional white matter tracts. It measures the flow of water in a unilateral or bilateral direction along axons. And then fluctuations in these values give us an indication of damage to that axon. So we get a value associated with that area where that particular voxel, and that helps us understand that the water diffusivity may not be normalized. And also, there's also DSI, which is considered a sensitive test that considers the bidirectional flow of water across those axons. So these are a couple of imaging techniques that you can use with functional MRI. We also look at magnetic spectroscopy, which looks at the detection of metabolites within the white matter and gray matter. We look at lactate, creatine, N-acetyl aspartate, and then choline. Those are measures of different sort of functional metabolites in the brain, and they're changed or compromised during sport-related concussion. So we can look at either whole brain ratios, we can look at specific areas. Ultimately, we just evaluate the presence or absence of these as they rise and fall over the time course of recovery from injury. A lot of the early work done by our lab, in addition to with Vagnozzi and others in Italy, is very pivotal in understanding the importance of magnetic spectroscopy. Another type of signal that we see in functional MRI is the use of what's called a BOLD signal, or blood oxygen level dependence signal. This gives us an understanding of the influx of blood as it correlates to neuronal activity. So if we activate a group of neurons, we see that activation leads to a change in localized blood flow. And a lot of the work that we did out of the lab here came back in 2010, 2009. A lot of the studies that we did here at Penn State actually laid the foundation for BOLD signal activation and its use in advanced imaging and scanning. We looked at that. We looked at BOLD signal activation in terms of its connectivity with different areas in both resting state or small world network function. And we've been able to confirm pathology using these measures. And that helps us understand the connectivity between largely associated major brain areas in the brain. And again, with diffuse tensor imaging, we look at FA values, so we can see that they're altered 30 days, 3 months, 6 months, up to a year in some instances. We see whole brain metabolic ratio imbalances 30 days or 120 days out, and then functional connectivity alterations can be years. So BOLD signal activation issues can be lasting in these people that are recovering from brain injury. Another form that's a little more clinical based, but also is used quite widely, is the use of electroencephalography. Man, I just breezed by it. So EEG measures the electrical potentials of the groups of higher order pyramidal cells. It looks at different frequency bands and then evaluates the alteration of those bands across the time course of injury. And what we know is that these bands and these power bands are influenced by injury, and that we can measure them and look at them and track their recovery over time. In addition, what we can also do is use electroencephalography, EEG. We can use it in conjunction with neuropsychological testing. In our lab at Penn State, we do a lot of virtual reality or balance tests. We do force plate measurements. So we can combine EEG activity with other modalities to help give us a really good understanding of the physiological underpinnings of performance and how. So in other words, if I ask an athlete that sprained their ankle to go run the 100, right, at that level, I can see that their doing a sprint is damaged. Over time, I see that they get better at it, and then from the discernible eye, it appears as though they're returning back to normal. What we don't see in the ankle is the recovery of structure and how that's correlated with function. So once somebody says they feel better or they're performing better on neuropsychological testing, what we're not seeing is how hard the brain is working and how many additional resources the brain is recruiting to provide that function. So we can see that they're functioning at what we call a normal level or back to baseline level, but they're actually really activating additional resources within the brain to do that. So that to us signifies that there's still an aberrant issue in the brain where it's recruiting abnormally parallel regions in the brain in order to reach out and sort of produce normative function. So EEG or fMRI are ways that we can measure the neurophysiological underpinnings of functional performance, right? So yeah, you also look for, with EEG, you also look for evoked potentials or epileptiform spikes or other little clinical features in EEG evaluation that aren't necessarily related to quantitative EEG evaluation. So in quantitative EEG, you look for absolute power of certain frequency bands. You look at coherence between different regions in the brain. We look in particular at long versus short distance tracks to see how resilient those tracks are and if there's any changes in normative function between those regional areas. And then finally with that, yeah.
Just real quick, wanted to, we'll keep going. I just wanted to let everybody know at the 30-minute mark, you know, this is very informal. If anybody needs to hop off, you're more than welcome to. We'll stay on, we'll continue. Just wanted to let everybody know and thank everybody for coming if they needed to hop off. Sorry, Mike.
Yeah, I'm bringing it home. I'm bringing it home. We're almost there. So with the hemodynamic response, FNIRS functions in a very similar way to DTI and also EEG. So there's very similar issues with that. And in the lab, we use all of these platforms: virtual reality, EEG, functional neuroimaging, as well as force plate stuff, and then virtual reality and center of pressure measurements. So there's a really good sort of combination of resources that we use. And Sammy, that's your grandson right there. Remember that picture. And then Katie Finelli, she's doing her VR picture there too. Some old school pictures. As far as treatment, so let's shift to treatment, right? We've got some, we'll talk briefly about nutrition. I'm going to give a shout out to some nutrition folks that are on the line. So nutrition, we'll look at the summary of rest, and then we'll look at a summary of exercise and what each of those areas promises for the treatment of TBI. So in nutrition, we look at how can nutrition influence some of these physiological processes, right? So for antioxidant use or neurometabolic intervention, there have been some studies that look at curcumin. It's a powerful antioxidant, anti-inflammatory, and it has cytoprotective capabilities that can potentially offset some of the damage that happens with neuroinflammation and then metabolic disturbances. There's been some studies out that look at function and structure of animals, and their curcumin supplementation has helped augment some of the lesion sizes and then mitigate some of the inflammatory responses. In addition, what's also in the literature are omega-3 fatty acids, right? DHA stimulates neurite outgrowth, supports overall neural membrane function and homeostasis, and helps reduce inflammation. And in essence, it helps also reduce lesion sizes in certain instances of fluid percussion injury in animals. So omega-3 has some backing to it, as well as some of these other things. And then vitamin E is also a power antioxidant that reduces oxidative damage, helps maintain energy homeostasis, and then helps with synaptic plasticity and angiogenesis. So some of these substances are very good, and they have a physiological effect in the brain. So again, physiology, we're treating physiology. Rest. So rest has sort of been under attack recently by the exercise group, but ultimately I don't think they can get rid of rest. There's some problems with the research surrounding rest. It's very difficult to understand its effectiveness because everybody prescribes rest in a different way. And so here you can see some of the examples here. There's just a large heterogeneity of research. It's inconsistently assigned, it's done at different times. And then they have different definitions of rest. What's rest? So, you know, you wouldn't think that'd be a difficult thing, but What's physical rest or cognitive rest, or the types of rest? When do you rest? How long do you rest, right? So we don't have a standardized way of evaluating the effectiveness of rest, although we still prescribe it. And in some of the TBI, early TBI research, rest is actually helpful, and actually early activity could be detrimental. So we need to be careful about our transition from this rest phase, which is needed, and then transitioning to exercise. You have to allow for some level of recovery in the brain before you introduce an aberrant stimulus. That aberrant stimulus can cause other problems, right? So again, rest shouldn't be given a bad rap. We should still be resting our athletes. The question becomes when and how do we reintroduce exercise, all right? And again, we're doing all of this research in the absence of neurophysiological biomarkers. We're trying to do this at a clinical level and not at a physiological level. Again, we're limited at best in what we're doing. Problems. So increased cognitive activity was associated with longer recovery times from concussion. So if there's a too soon, we're getting them back to cognitive efforts, then it lengthens their recovery time. In school age students, it can increase in concussion related symptoms when was reported when they immediately went back to school, right? So if we just put them back into these situations where they're going to be active cognitively, it can delay or slow down their progress. And then a 7-day period of rest prescribed at any phase in people that were experiencing post-concussion symptoms significantly improved cognitive testing and symptom reports. Again, those are functional measures. They're not physiological measures, but it did improve that person's clinical outcome, in particular with high school age athletes. So exercise, there's been a huge explosion of exercise research. And this was sort of sparked back in 2009, 2010 with some initial studies by Dr. Letty out of Buffalo, where he talked about the idea of subsymptom threshold exercise for post-concussion syndrome patients. What he did was some exercise-based recovery for athletes and non-athletes, and realized that the cohort that was prescribed exercise recovered in a much faster way than the people that were sedentary, right? So you added exercise to their prescription and they clinically recovered faster. What was also of note was that sedentary individuals given exercise recovered at a slower rate than athletes. Athletes recovered at a faster rate with exercise. And that has to do with the neurophysiological makeup of athletics and what exercise does to the brain as well, long-term wise. So again, there's a whole body of research with exercise and brain health. Here at Penn State, we also established that early on in 2009 or 2010, we established the physiological basis of the benefits of exercise. And Sammy, we did this study back in the early 2009 when we were looking at the effects of exercise in the people that were recovering from concussion, and we looked at it from a physiological standpoint. What we found was that exercise helped reduce or restore functional connectivity between areas. Now, we didn't understand the implications of that at the time, but given the findings that we're seeing from Letty and from others recently, we now know that that exercise helps restore a brain function and brain activity, and it does it in specific ways that are really widespread. And it's one of the only treatment approaches, again, that directly influence physiological biomarkers of the brain. Okay, you have a physiological issue, you want to get physiological solutions to the problem. And there are vascular benefits. Again, you get new vascular formation, you get strengthening of the cerebrovascular reactivity, you get restoration of normal perfusion in the brain across areas that are affected by brain injury. So there's a positive vascular response. There's also a positive neurogenesis or neuroplasticity response, meaning the release of certain cytokines help the brain recover. And we talked about this a little bit earlier. BDNF, interleukin-1, lactate, all of these substrates are produced as a result of exercise, and they help the brain recover in specific ways. And that's it. I'm bringing it home. There was a lot of information there. I hope everyone can wake back up. And if you have any questions here, I'll stop sharing now so we can go to the stadium view. That was thick and heavy, I know. Thanks for staying with me on that. But again, my underlying point here is to emphasize that concussion is not, hey, coach, I'm feeling better. Concussion has a lot more to do with what's going on with the physiology in the brain. And like I said, at best, we are lacking that information. So when we're trying to prescribe or we're trying to rush, or we think what we're doing in terms of getting an athlete back to playing or healed, we're not doing it because we're not understanding the full picture. We're understanding the functional components of what's going on. We're not understanding the physiological basis of recovery. And so with that, I will open it up for any and all comers.
Yeah, hey Mike, appreciate you stopping by and presenting that information for us. I did have a question in terms of whether that be damage to the brain or recovery time. And that's if you know, or if there's any evidence on the difference in those things between an individual that suffers a concussion to where he loses consciousness and one that doesn't.
Yeah, so what initially, you're right, John. So when we first started looking at concussion and some of the early grading scales, we counted loss of consciousness as a factor in terms of grading. What we understand now is that loss of consciousness does not necessarily give us an indication of severity. It happens to be an additional factor, but it doesn't tell us that that injury was more severe than another. It maybe gives us some insight into location of trauma, but it doesn't necessarily mean that severity is altered. So what we've done over the years is we sort of eliminated loss of consciousness as a criteria for increased grading. And now we're going to more symptom-based stuff, neuropsych stuff, functional measures, and then we look at that serially over time in their recovery in order to sort of classify somebody as recovered, quote unquote recovered.
Appreciate it, because I was just curious, because sometimes you'll see an incident that may happen on the field and it looked really bad, and compare that to an individual where it may be not as easy to identify where that brain injury occurred, that concussion occurred, and the one where it looked really bad could come back faster than the other individual. So appreciate that. Yeah,
no problem. Yeah, the fencing response that happens sometimes in the brain is usually very tough to watch, right? We see somebody sort of posture. It looks very similar to like a petit mal or grand mal seizure activity. But again, it's important to note, but that has been less of a factor in terms of
as far as let's say in terms of like drill design, practice design in some of our contact sports, for coaches, staff members that design these things, like what are things we need to keep in mind in the long term? Let's say somebody has a history of concussions, or maybe they haven't experienced one in a long time. Like, what should we do in terms of altering things, but at the same time, keeping in mind that we still have to train athletes? Are there ways that we can best serve them?
Yeah, so I think actually, what we're talking about and what's sort of come out in the research recently is that long-term healthcare and short-term healthcare are all sort of influenced in dose response. So meaning the more dose you get, the higher the response you're in. So for example, that plays out in some of the research where we look at the lifespan of some NFL athletes. We find that some of the NFL athletes, if they started really young in Pop Warner level or lower level, versus if they started in high school or even later in high school, maybe even early college, we find that typically, on average, people that start, we're talking about football, so I'll use football. The longer you're doing contact over time, the higher your risk component for downstream issues later in life. So when we're designing practice and we're designing drills, we should do anything we can to help limit that dose response, right? We can take away or mitigate some of the levels of hits. So for example, here at Penn State, we've identified early on through telemetry and other helmet sensors that linemen in some special positions took on a lot of low-level subclinical impacts over time. What we've done with that, with the introduction of the caps, and people were sort of critical of caps up front, but I think they have a utility because the caps help take those subclinical blows and take them from a measure of whatever 50, 60 Gs or what, that's probably way too high. Whatever the Gs are of those subclinical blows, and they take them and they lower them. Now, in that practice session itself, it doesn't make a big difference, but over the career of that athlete, now you're taking hits that are at 60 and you're lowering them to 30 or 20. And if you can do that over time, I think these little changes help in terms of influencing the dose response for that particular athlete. So obviously, if you can eliminate or take head contacts out of drills, that's always preferred. But if there's little ways that you can reduce the effect of impacts, I think those are the key factors when we're talking about long-term dose response and those athletes potentially going on to play later on in life, or if this ends up being the end of their sort of playing career. So any mitigating factors we can do to reduce traumas over time is going to benefit the athlete, in my opinion. I don't have any evidence to support that other than understanding that this is a dose response and less is better than more.
No, that makes a lot of sense. It really does. It's the accumulation that we're trying to avoid. So thank you.
I have a quick question as well. You spoke about some of the blood biomarkers being kind of an indicator of where they're at in their recovery physiologically. I guess my question is, how difficult is it to test for some of those blood biomarkers? And do you foresee that being kind of a part of the standard concussion protocol? Like, is it something as easy as, a finger prick that you can test their blood through that? And do you think that's going to be part of standard testing?
I would love to think so. We've been shoving swabs up our noses for about 8 months now. So I think the idea of spitting in tubes or doing mouth swabs or blood pricks or finger pricks would be pretty mild after this last 8 months. So I think I would love to see that. My question is, are we brave enough to accept the answers? So once we know our results and then we've attached importance to something, then that attachment of importance comes with a consequence. So what's been happening in academically over the years is there's a strong undercurrent to resist the idea that concussion is a lasting injury and it has a negative effect on the human body, because we don't want to hear that. We don't want to, at some level, accept the idea that we're hitting the brain and it's probably not a good idea. So yes, I think we can do it. We can do it today. The problem is that we meet every 4 years, and that paper or that group dictates how we function as clinicians. Whether we like it or not, we all refer back to this paper that gets put out every 4 years, and then every medical society accepts it as carte blanche, and that's how we're supposed to treat it. None of us have the courage to sort of take on these additional resources and then step back and say, maybe we need to wait until this marker is a little bit better. And here's why. Now, that's not the clinician's fault. Brain science hasn't done a great job at attaching importance to those areas. And there's also an undercurrent in the academia that doesn't want to, right? They want to stay in their own silos. And if we all of a sudden start creeping into the clinical, we'll get pushback from sport. And that happens in a heartbeat. It happens in research. It happens in anything you do. That's the problem when sort of sport or industry drives healthcare. So again, it's not that we can't do it. It's that no one's sort of taken the bull by the horns, established a protocol, and then had the guts to go out there and implement it. So I'm waiting for that. I think we should do it in the best interest of our student athletes and their long-term health. I absolutely think we can do it today if we wanted to. We just need to be better about communicating between our silos. Brain science has to do better about attaching importance to it, and clinicians have to accept the idea that brain science exists, and maybe what we're doing is incomplete. Sorry, that's sort of a soapboxy type answer. It's real touchy for me because I think we can be doing a lot better to serve our athletes and how we're.
No, that was great. Thank you. Got me a little fired up too.
Can you hear me? This is Jeff. All right. Yeah, it's probably more that there's not a lawsuit that's come to push that yet with the blood work. But anyway, you spoke a little bit about nutrition and potentially some vitamins that help with recovery. Is there any conceptual idea of prescribing some type of nutrition or vitamin base ahead of time before a concussion were to take place, mild where it's undetectable, or, something that's happened in the past that we don't know about to help recover? Is there an idea of that you could just prescribe that?
Yeah, absolutely. So there's a large variety of research the same research I was quoting in terms of their effect on concussion were actually research that was using those substances or supplements as a precursor before the injury. So they were already administering some of those substances, minerals, vitamins to the animals or to the people prior to injury or fluid percussion or sort of lab-induced trauma. So you can be using those substances or having a good multivitamin, using omega-3 fatty acids as a good foundation or help as a neuroprotectant. And some of the doses are in the literature. There's actually a few schools that actually have it as part of their concussion, post-concussion protocols. I think Georgia had something with prescribing omega-3 fatty acids for the duration of symptoms. And once they stopped symptoms, they went on to some maintenance dose or something like that. It wasn't necessarily evidence-based, but it was a shot in the dark at trying to include nutrition as part of their treatment regimen. So in terms of neuroprotective ahead of time, yeah, a lot of these substances as a daily use can be effective in mitigating some of the damage that happens in the brain resulting from trauma. So yeah, there's a large body of research. In fact, we've actually even studied some supplements here as part of the lab in that way. And I could give you a summary of some things. If anyone wants to reach out, I can do my best to give you a summary of some of those nutrients.
I'd love the nutrients and just maybe some basic literature behind it that we could present to some athletes and see if they're interested in that.
Well, if there are no other questions, we will.
Josh, can I make one short comment, Sam, on here? So that coming to the Adam, the question regarding the implementation of that blood biomarker in the clinical setting. That the problem is that logistically, we did this work and collected the blood sample prior to season, after season, but it's actually challenging. There's a lot of concern, and now that's kind of what, as we speak right now, we collected the blood sample pre-postseason football player and also collected saliva and send it to the Orlando Health right now, and the leading experts in the world in the blood biomarker and concussion research, Linda Popper, is actually doing validation study and comparing that microRNA inflammatory processes and comparing with the saliva, make sure that it's kind of consistent and robust and a valid test to assess what we can get for the blood. If so, it will be much easier logistically that's going to swamp and get a saliva sample and could be processed in the same way, and clinically that will be much more efficient to get some kind of implementation in clinical practice. So that's what we're actually going on right now. That in fact that this morning that James sent the sample and blood sample and saliva sample to the Linda, and Linda will be processing it in 2 weeks or 3. We will get something that idea would be possible to use the saliva instead of blood work. In this case, it will be simplify our task to prognosticate the evolution of injury over time in a quick manner, and it could be actually what Mike mentioned, that will be kind of great contribution to that's what we're doing right now. Thank you.
All right. Well, as always, thank everybody for being here. Mike, really appreciate the time and that you put into this, but also in preparing for this. And I'll continue to just kind of bring up the idea that this is very collaborative and we want to continue to build it. You brought up a great point earlier, Mike, that hit me was the disconnect at times between practice and academia. And then you look at what's going on campuses across the nation. There's experts in so many wonderful areas. And if we can break down any wall, whatever it may be, to help benefit our athletes and our coaches, that's what this is about. So definitely appreciate everybody. Next time, 2 weeks from now, we're going to have Cam Davidson from Strength and Conditioning talk. He is our men's ice hockey and women's volleyball strength coach. He's going to be talking about different aspects of high performance and how they use that within men's ice hockey. So definitely encourage everybody to join us, and really appreciate it. If there's anybody that needs anything, please reach out individually. And if not, have a great day.
Thank you.
Thank you, everybody, for coming.
Thanks, Mike. Thanks, Josh.
Thank you, guys. Appreciate it. Mike, man, thank you.
Thanks, brother.
Yeah, man.
That wasn't good. I liked it. Have fun.